Yeah, I think the reason why primary cares and OBGYNs don't really like to or don't really know how to optimize hormones is multifactorial. One of the first big reasons is this is not something that is taught in traditional medical school curriculum. For instance, my entire medical education included one 4-hour lecture on hormones. And it was only to address menopausal women and only if their symptoms were severe. So you have to go out of your way to learn how to do this. At this point, I'm thousands of hours into extended medical education on hormones because, and providers are not going to spend that amount of time unless it's something that resonates with them, if it's something that they're interested in and want to specialize in. So primary care providers and OBGYNs are just simply not taught how to do this. Also, there was a big setback in medicine in the early 2000s with a big study called the Women's Health Initiative. This was a big study done on Premarin and Provera, and they found an increased risk of breast cancer, stroke, heart attack, and blood clots in that study. And a lot of providers got super scared. They stopped prescribing hormones. Patients also got nervous and stopped taking them. And subsequent analysis of that data have kind of debunked some of those results. But to me, the biggest moral of the story of the WHI is don't use synthetic hormones. Because we do not see those risks and side effects when you use bioidenticals. And there are decades of data showing that to be true. But a lot of people or a lot of providers who don't understand the nuances of hormone replacement don't understand the difference between synthetics and bioidenticals, and they lump all hormones under the same umbrella and say all hormones have these risks and side effects, and that's just simply not true. And I think a third reason for this is that they don't understand the difference between normal and optimal. For instance, it's perfectly normal for a postmenopausal woman to have 0 ovarian hormones. That is literally the definition of menopause. But we also know that that is far from optimal because a woman's risk of cardiovascular disease, Alzheimer's, cancer, strokes skyrocket in the decades after menopause. So we are taught in medical school curriculum to rely very heavily on lab values as the determining factor on whether or not the patient warrants intervention or treatment. And so therefore, if you're looking only at lab values, menopause is normal and doesn't warrant treatment. Or if lab values come back within the normal range, the provider will call the patient and say, all your labs look great, even though you have all these symptoms and you don't feel well. They make no treatment plan or intervention with normal labs.